Hello all, this is Dr. Aishwarya Kanere. Welcome to the next video. Today we are going to discuss a very important topic which is hypertensive disorders of pregnancy. So let's begin. Firstly, what is the definition? So hypertension in pregnancy is defined as the blood pressure of greater than 140 by 90 on at least two measurements, ideally separated by 4 hours interval. Okay, so BP more than 140/90, two measurements at an interval of 4 hours, but not more than 7 days apart. This is the definition of hypertension in pregnancy. Then proteinuria, total protein of more than 300 mg per day in a 24-hour collection. Then gestational hypertension, BP more than 140/90 for the first time during pregnancy after 20 weeks. Okay, then BP returns to normal within 12 weeks postpartum. Okay, then there is also some definition of edema. There is pitting edema over ankles. So this is the leg. So there is a pitting edema over the ankles after 12 hours of bed rest, or excessive weight gain of more than 4 lb per week, which comes under one criteria of preeclampsia. Now what is preeclampsia? BP more than 140/90 for the first time after 20 weeks with proteinuria. In the absence of proteinuria, okay, if there is no proteinuria, there can be thrombocytopenia, less than 1 lakh platelet, deranged LFTs, new development of renal insufficiency, pulmonary edema, and visual or cerebral disturbance. Okay, so these are all the definitions. These are the definitions. We define hypertension, we define proteinuria. Gestational hypertension is without proteinuria but BP more than 140/90. Then there is preeclampsia, gestational hypertension with proteinuria. Then eclampsia, woman with preeclampsia complicated with grand mal seizures, okay, or coma, which is called as preeclampsia. Then there is HELLP syndrome, hemolysis, elevated liver enzymes, and low platelet count, which is HELLP syndrome. Then chronic hypertension, superimposed preeclampsia or eclampsia. Then next is chronic hypertension. Then chronic hypertension. What is chronic hypertension? BP more than 140/90 for the first time before 20 weeks. Or hypertension diagnosed before 20 weeks of gestation and persistent after 12 weeks of gestation, or known case of hypertension before pregnancy. Then there is something called as superimposed preeclampsia, occurrence of new onset of proteinuria in women with chronic hypertension. Proteinuria more than 300 mg per 24 hour before 20 weeks. Or a sudden increase in proteinuria and platelet count less than 1 lakh. In pregnancy, less than 20 weeks. So, what is superimposed preeclampsia on chronic hypertension? There is a new onset proteinuria in women with chronic hypertension. What is chronic hypertension? Less than 20 weeks. And new onset proteinuria. More than 300 mg per 24 hour in hypertensive woman, but proteinuria before 20 weeks of gestation. Or a sudden increase in proteinuria on blood pressure on a platelet count of less than 1 lakh in woman with hypertension, but before 20 weeks. That is superimposed preeclampsia or eclampsia. Okay, so these are the common causes of chronic hypertension. There is essential hypertension, renal disease, coarctation of aorta, endocrine disorders like diabetes. Then the criteria for diagnosis of superimposed preeclampsia: new onset proteinuria more than 0.5 gram per 24 hours, aggravation of hypertension, development of HELLP syndrome, development of headache, scotoma, and epigastric pain. You will memorize everything using this table. So this is a very concise and a very a good table for your exams. Then we move on to the risk factors of for preeclampsia. So what is preeclampsia? I will revise it again. Gestational hypertension, that is BP more than 140/90 for the first time in pregnancy after 20 weeks without proteinuria, and plus there is proteinuria in preeclampsia. So now we will discuss the risk factors of preeclampsia. Okay, so risk factors are a primigramida, a young or elderly woman, first time exposed to the chorionic villi. Okay, first time she is exposed, so she is primigravida, young, elderly. Then there is family history of hypertension and preeclampsia, then placental hyperplacentosis, molar pregnancy, twin pregnancy. So firstly, we saw primigravida, young. So you can remember it as a history, 21-year-old primi. Okay, came for the first time in the OPD with a family history of hypertension and preeclampsia, and also with a history of molar pregnancy twins, that is hyperplacentosis, and who is obese, that has who has a BMI of more than 35. Okay, or a pre-existing vascular disease, thrombophilias. Okay, so you can remember it as a story. Okay, then we move on to the etiology of preeclampsia. So hypertension, there is endothelial dysfunction, and there is vasospasm because of that, increased circulating pressor substances, increased sensitivity of vascular system to these pressor substances, to the pressor substances. Then we have the trophoblastic invasion and uterine vascular changes. Normally, the endovascular trophoblastic tissue in the walls of the uterus, in the walls of the spiral arteries of the uteroplacental bed, then trophoblastic invasion. Normally, the trophoblastic invasion takes place by the endovascular trophoblastic tissue into the walls of the spiral arteries of the uteroplacental bed, usually in the first trimester. It takes place at around 10 to 12 weeks up to the decidual segment, and in the second trimester at 16 to 18 weeks up to the myometrium. In preeclampsia, on the other hand, failure of second wave of trophoblastic invasion of endovascular trophoblastic invasion decrease blood supply to fetoplacental unit. Normally, the angiotensin 2, which is an alpha 2 globulin, it is destroyed by angiotensinase, and the BP is stabilized, which is normal. Okay, then PgI2 nitric oxide, which is a vasodilator, stops platelet aggregation, stops intervillous thrombosis, and then there is one more factor, that is VEGF, that is mitogenic glycoprotein. Okay, that has a mitogenic glycoprotein. All these, they restore uteroplacental flow to normal level. Okay, so these were all the etiopathologies of the preeclampsia. Okay, in preeclampsia, again, there is a disturbance in the pressor substances, imbalance in the different components of the prostaglandins. Okay, so there is decrease or deficiency of PGI2, which is a vasodilator, increased PXA2, thromboxane A2, which is a vasoconstrictor, and increase the vascular sensitivity to angiotensin 2. Okay, which is a pressor agent. Angiotensinase activity is decreased. Okay, there is decrease in the nitric oxide. Okay, so how is it synthesized? It is synthesized from vascular endothelium from L-arginine. So it in short causes hypertension if decreased. Then endothelin 1, which is a potent vasoconstrictor. Then inflammatory mediators like T, TNF alpha and interleukin 6. Then abnormal lipid metabolism. Lipid peroxidases are produced like ROS, SONion radical. Then there are platelet plus neutrophil activation and T angiogenic SFLT1 bind with VEGF and PLGF. It causes endothelial cell dysfunction. Then there is also something called as factor 5 Leiden deficiency. Then there is edema, as we already discussed. There is increased oxidative stress and there are leaky capillaries. Proteinuria. This is important. Spasm of efferent glomerular arterioles, anoxic change, glomerular endotheliosis, leakage of proteins, damage, then leakage, and tubular reabsorption decreased. Albumin 50 to 60% and alpha globulin can be 10 to 15%. Then there is one factor that is protective. Smoking is a protective factor for preeclampsia. We have the pathophysiology. So, primary wave of trophoblastic invasion, that is 12 to 14 week. Then secondary wave, that is at 16 week. The spiral arteries are high velocity, low resistance, which is normally seen, and abnormal trophoblastic invasion. Then spiral arteries become high resistance and low velocity. Then there is decreased blood flow to the fetus, uteroplacental hypoxia. Then inflammatory mediators, cytokines, vasoconstriction, capillary breakage. There is edema. Then vasoconstriction can be maternal, hypertension in fetus, causes IUGR, oligo. Then preeclampsia is generally seen in a primary, and it is seen 70% in a primary gravida. In the pathophysiology, the uteroplacental bed, premature aging of the placenta is present. So, more points to the pathophysiology. Premature aging of placenta, villi, syncytial degeneration, thick basement layer. In preeclampsia, normal endovascular invasion fails to occur. Obliteration of lumen due to atherosclerosis of spiral arteries. Then it affects the kidney. As we discussed, there is glomerular endotheliosis. Fibrin is deposited in the basement membrane. This is the glomerulus, then there is the basement membrane, and the lumen occludes. Decrease in the GFR, 25% it is. Bilateral renal cortical necrosis. Blood vessels, vasoconstriction, liver, periportal hemorrhagic necrosis, or a subcapsular hematoma is seen. Okay. And the another one is HELLP syndrome. Hemolysis, elevated liver enzymes, and low platelet count, less than 1 lakh. Microangiopathic hemolytic anemia, schistocytes or Burr cells, and there are symptoms like nausea, vomiting, epigastric pain, and right upper quadrant pain. Liver enzymes, what do they show? AST, ALT more than 70 international unit, LDH more than 600, and bilirubin more than 1.2 mg per d. Okay. And due to subcapsular hematoma, there is sudden hypotension, hemoperitoneum can also be seen here. Then in preeclampsia, the HELLP syndrome, we will elaborate the HELLP syndrome a bit. In this HELLP syndrome, as we already discussed, there is hemolysis, there is AST, ALT which is elevated, and there is one classification also called as the Mississippi classification. In this Mississippi classification, there is class 1, 2 and 3. So the platelet is less than 50,000, 50,000 to 1 lakh, and 1 lakh to 1.5 lakh. Okay. AST, ALT more than 70, more than 70, more than 70. And LDH everywhere more than 600, more than 600. So it basically depends on the number of platelets. Okay. And the management of this HELLP syndrome is blood transfusion, that is platelets, hypoglycemia correction, correct, injection vitamin K, IM, steroid, then preventive measures for hepatic NCAF, treat, MAXELF is given, MGSO4, then hepatic encephalopathy is treated, and magnesium sulfate prophylaxis is given. Then post-delivery monitoring is mandatory. Then We move on to the management of preeclampsia, but before that, we will just see a table, the etiology of preeclampsia. So you can see normally there is vasodilation, there is platelet aggregation, and uteroplacental blood flow is increased. That is PGI2 and PGE2. Okay, then there are some other factors like VEGF, nitric oxide, vascular refractoriness to pressure agents, which is because of angiotensin 2, which degrades. Which is degraded by the angiotensinase, which keeps the BP normal. And there is also some thromboxane A2. Okay, now in cases of preeclampsia, there is oxidative stress, lipid peroxidases, ROS, and superoxide radicals, then SFLT, endoglyne, and then there is vasospasm by endothelin also. Increase in vasoconstriction causes hypertension, decreased organ perfusion, uteroplacental IUGR, HELLP syndrome, endothelial dysfunction, capillary leak, ascites, then hemoconcentration is seen. So this one is preeclampsia and this one is normal. So it is a arachidonic acid pathway by cyclooxygenase which releases the prostaglandins. The there is the main issue is endothelial dysfunction occurs, and there is hypertension, increase in vasoconstriction, then cytokines like TNF alpha and interleukin 6 are also released. Okay, then there is deficiency of this vasodilator, which is PGI2, the VEGF. Nitric oxide is also a vasodilator. VEGF is vascular endothelial growth factors. Then the next is, see, you can see there is marked pitting ankle edema here, marked vulval edema in preeclampsia. There is the vulva and this is the. So next we talk about the management of preeclampsia. We usually give Maxelf. Maxelf decreases the interventricular hemorrhages. It also decreases the necrotizing enterocolitis, and it also decreases the perinatal asphyxia. Corticosteroids can also be given. They are given for lung maturity. And usually the management is lower segment cesarean section. Okay. So then, except in less than 34 weeks, we advise bed rest, plasma volume expansion, 5 to 25% albumin, dipyridamole, steroids, and FFP. Okay, so management is Maxelf, then corticosteroids, termination LSCS, except in less than 34 weeks, where there is bed rest, plasma volume expansion, dipyridamole, steroid, and fresh frozen plasma. We move on to the complications. In the complications, there are maternal complications. There is abruptio placentae, then there is DIC, acute renal failure, severe ascites, then pulmonary edema, pleural effusion, cerebral edema, ARDS, sepsis, and death. Then perinatal, preterm delivery, RDS, respiratory distress syndrome, sepsis. Then in the brain, there is Press syndrome, which is most commonly seen in cases of preeclampsia, which is posterior reversible encephalopathy syndrome. Then it can cause hypertension, seizure, vision changes, altered mental status, bilateral, symmetrical, vasogenic edema, occipital, and posterior parietal lobe are affected. They are usually affected. Then heart, subendocardial hemorrhage, lung, as we already discussed, ARDS, water and electrolytes, salt retention, increases post delivery, extravascular, 2 goes to intravascular. Hmm? Okay. If fails, there is postpartum vascular collapse. If this process fails, there is postpartum vascular collapse, which means that the fluid remains in the extravascular compartment and does not go to the intravascular compartment. Okay. Then hematological, increase in the hematocrit, hemoglobinemia, HB urea, hemoglobin urea, DIC, increased thromboplastin, increased fibronectin, D dimer, and thrombin. All of them increase. Okay. Then hormone, HPL increases, HCG increases. Okay. Then serum creat increases. Okay. Hyperhomocystinemia, serum uric acid, okay, increases more than 4 mg per deciliter. Then there is also renal involvement. Okay, so these are the complications that can occur mostly in cases of preeclampsia. So there is a list of complications, and the main complications are maternal, that is abruptio placentae, DIC, and perinatal preterm delivery. Brain is the Press syndrome, that is posterior reversible encephalopathy syndrome, and lungs, ARDS. Then hematological, increase in the hematocrit, serum creatinine and serum uric acid increases. So these are the parameters that have to be tested while evaluating for preeclampsia. Then we move on to the clinical features of preeclampsia. So, we will start with the clinical features of preeclampsia. It is also called as the preeclampsia syndrome. In this, the symptoms appear late, mild swelling over the ankles, that is tight ring on finger. Okay, then it moves on to the face, the vulva, and then the whole body. Increases on rising from the bed. Then there are alarming signs. These signs you have to know. There is headache. This is for the mother. Headache, which is because of cerebral vasoconstriction. That is occipital and frontal lobes are usually affected here. Then there is scotoma, blurring of vision because of retinal arterial vasoconstriction. Then there is blindness, occipital ischemia. Then there are some reversible symptoms, which is irreversible pulmonary edema. Then there is epigastric pain, hemorrhages due to rupture of the small blood vessels under the liver capsule, which is also called as the Glissen's capsule, and there is also uh, splinter hemorrhages in the Glissen's capsule. So there is epigastric pain here. Then there is one more symptom, which is oliguria. Okay. Then there is disturbed sleep. Other symptoms: disturbed sleep. Then decreased urine output, oliguria, less than 400 ml in 24 hours. Vomit, coffee color, hemorrhagic gastritis. Then there are signs. Symptoms is what the patient will present to you with. Then signs is what you will observe in a patient. That is abnormal weight gain, more than 4 lb per week, increase in BP, edema over ankles, CVS or renal pathology, pulmonary edema, leaky capillaries. Then placental insufficiency, rapid weight gain, hypertension plus proteinuria. In urine, the proteinuria 10 to 15 gram per liter. Then in ophthalm, the V by A ratio is normally 3:2, which decreases to 3:1. That is nicking of the veins. Then the blood volume, increase in the serum uric acid as we saw. Serum creat, more than 1 mg per deciliter. And hepatic liver enzyme increases. Okay. Then there are complications, that is immediate complications. We have already seen the complication, just an overview. Immediate complication, maternal complication during, so it is divided into during pregnancy, during labor, and during puerperium. So during pregnancy, there is eclampsia plus PPH, acute, subacute, accidental, hemorrhages, oliguria, and anuria, HELLP syndrome, preterm labor. Eclampsia plus PPH. PPH will come during labor. It won't be a part of during pregnancy. Then we have the puerperal period, that is eclampsia, less than 48 hours, sets in less than 48 hours, plus shock, plus sepsis. Then fetal IUGR due to placental insufficiency. Then we have remote. First was immediate, then is remote, that is residual hypertension, renal disease, that to chronic. This persists beyond 6 months, the residual hypertension, placental abruption. Then screening test for prediction and prevention. For prediction and prevention, uterine artery, Doppler, mean arterial pressure, PAP-A, PGF, 11 to 13 weeks. Okay, in Doppler, diastolic notch. This we will see in detail with the images at 24 weeks. Just remember, in Doppler, diastolic notch at 24 weeks, renal disease, we have already seen, increased uric acid. And because of this diastolic notch, there is FGR, increase in the mean arterial pressure, that is 90, more than 90 mm of Hg in the second trimester. Increase in the serum maternal SFLT1, which causes preeclampsia. Then prophylactic measures. Okay, measures for prevention. ANC checkups. Low dose aspirin. Why? It is given from 13 to 26 weeks till 36 week. Why aspirin? Aspirin inhibits COX in platelets and no platelet aggregation by thromboxane A2. LMWH is also given. Calcium supplement, which decreases gestational hypertension. Vitamin C and E can also be given in all these cases. Okay, so there is presence of diastolic notch. Now, what is the presence of this diastolic notch? Then we saw the diastolic notch at 24 weeks. Here is the image of the diastolic notch at 24 weeks. Now, we will see the clinical features. In the clinical features, we have already discussed the preeclampsia clinical features. In the primary, it appears 70% in the primary, and it appears after 20 weeks. Okay, and the diastolic blood pressure is more important than the systolic blood pressure. Then the clinical types are non-severe, BP more than 140/90 but less than 160/100, and severe is more than 160/110 with proteinuria with oligo less than 400 ml per 24 hour. Platelet less than 1 lakh, elevated liver enzyme, then cerebral or visual disturbance, retinal hemorrhages, serum creat more than 1.1, pulmonary edema, and IUGR. So this is one kind of severe and non-severe. Then, um, then we have the prevention of preeclampsia. In the prevention of preeclampsia, we have already seen what can be given. We give aspirin 75 mg, which is low dose while sleeping. Okay, then or 150 mg. This is by NICE guidelines. This is by Aspire guidelines 150 mg, and calcium, that is 1500 mg per day. Now we usually send the PIH profile. In the PIH profile, we give the hematocrit, PCV, HB decreases, there is thrombocytopenia, serum bilirubin more than 1.2, increase uric acid, increase LDH, increase in AST, ALT, increase in creat, broken RBC, schistocytes, and there is microvascular hemolysis. Then the fetal well-being. In the fetal well-being, it is given by non-stress test or USG with Doppler. Okay. So we have seen the umbilical artery Doppler here. This is the normal flow. Okay. This is the normal flow which is given. Then absent diastolic flow. See, there is no diastoles. And this is the reverse diastolic flow. When the systole S/D ratio is more than 3, it is called as reduced diastolic flow. Then umbilical artery velocimetry. Reduced end diastolic flow, deliver at 37 weeks. Absent end diastolic flow, deliver at 34 weeks. Reversal of diastolic flow, 30 to 32 weeks. Deliver. Okay. Management of gestational hypertension. Okay, so gestational hypertension and preeclampsia management. Here we have already discussed, that is non-specific, antihypertensive, and MAC-self when there are impending signs. We have also seen the impending signs. And specific is termination. So antihypertensive, labetalol, drug of choice, BP 150/100, target BP is 130/140 or 140 systolic. Okay, 130 or 140 by labit, 130 or 140, and diastolic BP 80 to 90. Okay. Other drugs, nifedipine, alpha methyl dopa, hydralazine, nitroprusside. Then specific, these were all non-specific management. Then mild preeclampsia, deliver by 37 week. Severe we have seen with all the impending signs, deliver by 34 weeks. Hypertensive emergency, IV Labit, drug of choice, 20 mg IV, increase to 40 mg, then 80, then again 80, maximum dose 220 mg. Contraindication, ACE inhibitors, diuretics, ARBs. Okay. Immediate termination, impending eclampsia, eclampsia, HELLP syndrome, abruption, reversal, fetal distress, uncontrolled BP. Okay. So this was all about preeclampsia. Now we will just see in short about the management of preeclampsia. In the management of preeclampsia, hospitalization, rest, BP check 4 times, then all the lab parameters have to be sent, then ophthalmoscopy, fetal well-being, non-stress test, cardiotocography, then antihypertensive if diastolic is more than 110, lab it, IV, hydralazine, nifedipine, per oral, then complete control, preterm discharge to attend to the clinic, term to stay in the hospital, more than 37 weeks delivery, BP persistently high, try to continue till 37 or at least 34 weeks deliver, persistently high BP in spite of using the antihypertensive, then addition of other symptoms, restlessness, tachycardia, tachypnea, couple counseling, transfer to a tertiary care center, prophylactic anticonvulsant, then induction of labor has to be done by PGE2 ARM or oxytocin or cesarean section, and then postpartum monitoring is very, very important in such patients. Then the commonly used drugs in management of preeclampsia, that is methyl dopa, labetalol, nifedipine, and hydralazine. Their mode of action is central and peripheral anti-adrenergic action, calcium channel blocker, and nifedipine is a calcium channel blocker. Labit is adrenoreceptor antagonist. Then hydralazine is vascular smooth muscle relaxant. All the maximum doses are given here. Methyl dopa 250 to 500, labetalol 100 mg TID or QID. The most common one is labetalol. Hypertensive crisis can be used when the BP is more than 160 by 110. That is C. Commonly used drugs in hypertensive crisis, that is labetalol 10 to 20 mg IV, maximum doses 240 or 220, nitroglycerin or sodium nitroprusside. Just a basic overview of the management of preeclampsia. First is hospital and home treatment. There is rest and high protein diet. Then there is hospital, left lateral position, then rest, protein, 100 gram daily, decreased fluids, diuretics, no, but they are used in cardiac failure, antihypertensive drugs are used in, and in hypertensive crisis also they are used if BP is more than 160 by 110. Then duration of treatment, time of treatment, that is duration, termination in group A, where the preeclamptic features subside and hypertension is not severe. So preeclampsia is less and hypertension is also not there. Okay, less than 34 weeks, 90% develop recurrence. More than 34 weeks, keep in hospital till 37 weeks. It is there, it is not cured in less than 34 weeks. Okay, then group B, there is preeclamptic features and there is partial control. More than 37 deliver, less than 37 monitor. Then group C, terminate, increased BP, severe, HELLP syndrome. Okay, MAC-self is given. Acute fulminant preeclampsia. It is a preeclamptic state, threat of convulsion, then cerebral hemorrhage and cardiac failure. Treatment is sedate, midas, MgSO4, IV labit. Okay. Steroid less than 34 weeks prevents neonatal RDS, IVH, then this is all about the acute fulminant preeclampsia and the management part of the preeclampsia. Now we move on to what is eclampsia. So what is eclampsia? Severe preeclampsia with generalized tonic-clonic seizure which cannot be attributed to another cause. Then antepartum eclampsia. Antepartum eclampsia in pregnancy, it is most common in pregnancy. Intrapartum during labor. Postpartum within 48 hours of delivery. And there is MRI finding subcortical white matter edema. Most common cause of death is intracranial bleed. Intracranial bleed. Then causes of convulsion are anoxia, cerebral blood vessel spasm, okay, increase in the resistance, fall in cerebral oxygen consumption, anoxia. Then cerebral edema, cerebral dysrhythmia, excessive excitatory neurotransmitters, glutamate, loss of cerebrovascular autoregulation. Most commonly antepartum, it is in the third trimester where 50% of the convulsions occur. Intrapartum 30%, postpartum 20%. Then intercurrent antenatal conscious after recovery from convulsion. Then clinical features. In the clinical features, there is premonitory stage, unconscious, twitching of face and tongue, eye rolling, 30 seconds this happens, all these symptoms. Then there is a second stage, this is the premonitory stage, and there is a tonic stage. This also occurs for 30 seconds. Tonic, spasm, decreased respiration, tongue protrudes between teeth, cyanosis, fixed eyeballs. Then there is clonic stage, voluntary muscles, contraction and relaxation, biting of tongue, blood stain, frothy secretion, and then there is a stage of coma. There is a quick succession which is called as status eclampticus. The clonic stage is 1 to 4 minutes. We have the management. The management during fits, that is a mouth gag removed after clonic phase is over. Then air passage should be cleared off. Turn the patient towards one side. Raise the foot end of the bed. Raise the foot end of the bed. Oxygen until cyanosis disappears. Status eclampticus, thiopentone sodium. Thiopentone sodium is usually given, and according to the MACP trial, the drug of choice is MgSO4. It blocks the NMDA receptors, cerebral vasodilation, and blocks the calcium channel. There are two regimens according to which it is given. That is the loading dose, that is the Pritchard regimen, and maintenance dose is also given. Intramuscular is Pritchard, intravenous is Zuspam. So 4 gram IV over 3 to 5 minutes, followed by 10 gram IM, 5 gram in each buttock, then 4 to 5 grams slow over 10 to 15 to 20 minutes, 5 gram IM 4 hourly in alternate buttock, and 1 gram per 1 to 2 gram per hour IV infusion. Monitoring of magnesium toxicity, loss of DTR, decreased respiratory rate less than 12, urinary output, chest pain, heart block management, stop magnesium, estimation of serum magnesium and creatinine levels, injection of calcium gluconate 10 ml, 10% solution IV. Okay. Then usually the reflex that we talk about here is the patellar reflex. Okay, the deep tendon reflex, patellar, is the first to be lost in magnesium toxicity. If lost, stop it. Okay, stop magnesium sulfate 24 hours after last attack or delivery, whichever is later. Then therapeutic dose is 4 to 7 milliequivalents per liter. Okay, so monitor three things. Lost at 10 milliequivalents, it is lost at 10 milliequivalents. 4 to 7 is the therapeutic range. Then respiratory 16 to 18, respiratory depression at 10. Okay, then urine output more than 30, mag self is excreted unexchanged in the urine. If creatinine is increases, half the dose. Okay, antidote calcium gluconate. Then mode of delivery, try can be given as vaginal. Okay, if it takes more than 24 hours, try for LSCS. Okay, indications for CS: gestational age less than 32 weeks, fetal distress, IUGR. Okay, other benefits: neuroprotection, uterine relaxation. So this is all about the hypertensive disorders in pregnancy. Also, there is medical management, call for help to put the patient in left lateral, maintain oral oxygen, then connect IV lines, Foley's catheter to monitor the oxygen, control the seizures, Maxelf is given, then to monitor the vitals, fetal status, then crystalloid suction, oropharyngeal suction is done, then diuretics, pulmonary edema, and in cardiac failure, it is also given. Indications of intubation: patient remains unconscious, seizure not controlled, signs of aspiration and persistent hypoxia. Then there is obstetric management to continue medical management. Then not in labor, fits control, term, preterm and dead delivery, it is by induction and or cesarean section, introduction of labor if the fetus is dead. Magnesium sulfate should be continued 24 hours following delivery or after last seizure, whichever is later. Then fits not controlled, non-reassuring, deliver. Then in labor, ARM, forceps or ventouse delivery, or cesarean section, which is an obstetric indication. Okay, there is a multidisciplinary team approach involving obstetrician, anesthetist and critical care unit. Then So the therapeutic range is 4 to 7. Yeah, the patellar reflex is lost at 10. Then respiratory rate is at 12 or 10. Okay. Then maternal complication, injuries, tongue bite, pulmonary edema, hyperpyrexia, cardiac failure, then cardiomyopathy, renal failure, neurological deficits, disturbed vision, postpartum shock, sepsis, and psychosis. Then see neurologic imaging showing multi-lobe, cerebral occipital lobe abnormalities, intense T2 weighted. See, then preeclampsia, gestational hypertension, and essential preeclampsia is usually in the young. Then primigravide, past history preeclampsia and previous pregnancy. Family history may be present after 20 weeks, usually in the third trimester. After 20 weeks of pregnancy, gestational hypertension, yes, usually in the third trimester it is, and then it subsides completely. Both subside completely. Then eye changes, no. In gestational hypertension, no eye changes, but in preeclampsia, constriction of arterioles, hemoconcentration, thrombocytopenia, serum uric acid more than 5, raised liver enzymes. Then the gestational hypertension, the specific blood values, all this is absent. Okay, and in essential hypertension is usually in the elderly, multipara, before 20 weeks of pregnancy, and silver wiring of the arterioles, hypertensive retinopathy. So this is all about the preeclampsia and the eclampsia. So monitoring of a patient in preeclampsia on max self, pulse, respiratory rate, SpO2, temperature, lung sounds, deep tendon reflexes, that is the patellar reflex, and then fetal well-being. See, every 10 to 30 minutes pulse BP has to be taken, temperature every 2 hours, deep tendon reflexes every 4 hours, intake and output record, IV crystalloids. Then indications for delivery without delay in severe preeclampsia, persistent symptoms, pulmonary edema, hepatocellular injury, abnormal coagulation, oliguria, FGR, eclampsia. So this was all about hypertensive disorders in pregnancy. Hope you liked the video. Do subscribe to the channel. See you in the next video.